May I introduce you?
You sure can. Let's do it.
I'll come up so that it's recorded.
Yeah, we
like
Okay.
Oh, recorded.
Yeah, we're recording.
Good morning, everybody. My name is Shanda Demarest. I have had the pleasure of serving as BYang's DNP advisor for about the last year plus, and I'm excited to introduce her today to do her public presentation of mitigating a nursing school's impact on climate change, a quality improvement project.
Perfect. Thank you so much, Shannon.
Take
Appreciate
it,
it. Alrighty. Hello, everyone. How's everyone doing? Can you hear me?
Yes.
Okay, perfect. Alrighty. So again, quick thank you to Shannon for being my DNP project advisor, and quick thank you to Connie for being the community partner as well. Alright, so I'm going to start by giving you a brief background on climate change, and this is really keeping things really short and sweet. So long story short, the overproduction of carbon dioxide and other greenhouse gases from the burning of fossil fuels and human activities, that traps the sun's heat in the Earth's atmosphere. And so over time, this trapped heat, it causes global temperature to increase, leading to abnormal heat waves, irregular periods of droughts, shrinking land-based glaciers, increasing sea levels, and changes in ecosystems that reduce biodiversities. And these environmental effects also impact population health because they contribute to food and clean water scarcity. They also increase incidence and severity of respiratory, cardiovascular, vector-borne, zoonotic, waterborne, and foodborne diseases as well. And so the bottom line is climate change impacts all of us, from humans to animals to the environment and the planet. And then I'm going to switch gears to my literature review real quick. I want to first highlight that what the literature had to say about mitigation and environmental sustainability. So mitigation is one approach to addressing climate change. It focuses on reducing carbon dioxide and other greenhouse gas emissions. On the flip side, environmental sustainability is one aspect of climate change mitigation. And it's a framework that considers, how the planet's natural resources can be maintained and preserved. Current and future generations' health opportunities. And I also want to highlight real quick what the literature had to say about mitigation in nursing. And so the grand takeaway here is that nurses play a critical role in climate change mitigation to prevent the health impacts of climate change. And some of the things that nurses can do, they can design climate change-focused curricula, they can educate others, they can spread awareness, and they can connect the relevance, and I also want to add the urgency of climate change and environmental sustainability to policy and practice change. And these are all examples that both Shannon and Teddy do a really wonderful job at. And I'm going to switch gear here. The literature also highlights 4 themes. So I also want to highlight here, there's 4 themes that you can find in evidence-based recommendations in the literature when it comes to mitigation in higher education institution. So I call these the 4 Ps. So the policy part, the people part, the processes, and then also the practice part. So for policy and people, you need to have engagement and support from administration, leaders, and policymakers to create, to sustain, and to improve policies that guide environmental sustainability initiatives. And you also need to engage the frontline people as well as your community members. And then for processes and practice, the opportunities there lies in working with your stakeholders to improve your processes that support environmental sustainability initiatives as well as your curricula, your practices, and your campus operations. And now I'm going to switch gears to talk about my project aim and framework. So I want to disclose here that I did an organizational needs assessment first, and through that process, we identified 3 gaps. The first one is that there's no formalized group to plan and execute environmentally sustainable initiatives. The second gap is that there's no standardized process and infrastructure to promote environmentally sustainable behaviors and practice. And this is evidenced by variation in the trash and recycling bin configuration all around campus, the School of Nursing campus, and there's no bins for organics recycling. Last year when I implemented, but this has changed. So now the School of Nursing has organics recycling. And then the third gap is there was variation among stakeholders' practice when it came to the reduction of energy use and proper waste disposal. So some evidence of this we saw was there were lights left on in unused rooms. There was a high waste disposal of non-recyclable items. And there was also inaccurate waste disposal and trash and recycling bins. So for example, you would find non-recyclable items in the recycling bins, and vice versa, you would find recyclable items in the trash bins as well. And so what my project aimed to do was it aimed to mitigate the School of Nursing's impact on climate change. And now I'm going to take you through and kind of highlight the theoretical framework that I use. And I'm also going to pause to catch my breath because I'm going really fast. Alrighty, and so I use the Institute for Healthcare Improvements as model for improvement as the guiding theoretical framework for my project. And so to kind of recap it for anybody who isn't familiar with it, it essentially has two components. The first component asks us three questions. What are we trying to accomplish? How will we know if a change is an improvement? And what changes can we make that will result in improvement? And then the other component is the PDSA cycle, which stands for your plan, do, study, and act. And so to tie this back to my project aim fit nicely with the first question. And then the second question, we would know that there was when a change is an improvement by when we see positive changes in our environmental and sustainable behaviors among faculties and staff. And so this would be evidenced by improvements in their response rate, in their self-report behaviors on the post-Noise November survey, which I'll talk about later, and also evident by when we compare recycling to landfill proportion on the School of Nursing's campus. And then what changes can we make that will result in the improvements? These are actually my three interventions, which I will talk about later. And so now I'm going to switch gears to my method section. So a quick overview of the setting. I'm sure everybody here is either a faculty or a student, so you kind of know the School of Nursing already. There's two campuses. There's a metro campus here in Weaver Dunsford Hall, and then there's a rural campus in Rochester. Okay, I'm going to slow down, I promise. I said I would and then I didn't. Alrighty, so to keep it short and sweet, Weaver Dunsford Hall, it houses office and laboratory offices and spaces and classrooms for both the School of Nursing and the School of Pharmacy. And then the school's main office and workspace are in the 2nd, the 4th, the 6th, and the 5th floors. So who are on the project team? That includes myself, Shanna, Dean Delaney, members of the operations committee, which includes Curtis, CJ, and other departmental leaders. It also includes our cooperative unit leaders from Ruth and Gina to Wendy and Tracy and Cheryl Breed, and also includes our facility leaders, which includes Donald and Mike. And so now I'm going to kind of show you and talk about, I'm going to do a deep dive into my interventions now. So I just brought the slide back to recap and tie this back to the literature. So there were three interventions that were implemented during my DP project, and these three interventions they tie back to the peoples, the processes, and the practice themes that I talked about earlier. So the first intervention was creating a sustainability champion work group, and this work group was formed within the governance structure and the workflow structure of the operations committee. And when this group met, they narrowed down from a list of like 15 to 16 initiatives, they narrowed that down to about 10. And so figure 2 on the slider shows you the list of the 10 initiatives that they wanted to work on. Let's see. And these initiatives, they are to address the 3 gaps that I identified earlier. And then the second intervention is the No Waste November social campaign. And this campaign aimed to not only raise awareness about environmental sustainability and the human contributions to climate change, but it also engaged our stakeholders, so our faculty and staff, to pledge personal goals to reduce waste along the lines of materials and supplies, food and water, and energy. And then last but not least, the third intervention is an electronic sustainability dashboard. And so this dashboard served as a repository for some of the resources that we provided during the campaign. And so I guess it's on your right side. On the right side is a snapshot here. So I'm not going to read through the list, but some of the links, one of the resources that were available was links to information on local, seasonal, and organic food options. And then I'm going to switch gears here to talk about the measurements that I use to evaluate the impact of my intervention and my data analysis. So the first thing I used was a pre and post No Waste November survey. And what this survey did was it asked our stakeholders to use a Likert scale to rate how often they engaged in environmentally sustainable behaviors in 4 categories. So there was energy, recycling, materials and supplies, and food and water. And I also want to note that this survey was adapted with permission from the Nurses Environmental Awareness Tool. And below there you can see what the Likert scale included. And then also just wanted to also note that this survey went through several PDSA cycles with feedback from the project team before we finalized them for use, and that's provided the surveys with a degree of face validity. And then logistically speaking, the surveys were distributed by email to a listserv of a total of 156 faculty and staff. The first survey went out a month before the campaign, and then the last survey went out the first week of December. And then the other thing that I used to measure the impact of my interventions was waste disposal weight measurements. So for 6 weeks, what I did was I measured the weight of trash from the recycling and trash bins in high traffic areas on the 2nd, 4th, 5th, and 6th floor of Weaver Densfer Hall. And figure 4 here just kind of shows you a snapshot of some of the things that I encountered as I was weighing waste. And then quickly here for my data analysis, the pre and post survey were analyzed using descriptive statistics. I just wanted to note here that statistical significance was not measured due to how low the sample sizes were, and also because there was this statistical problem of multiple comparison. And so I can speak more to that later if folks have questions about that. And I also want to note here that survey data where people selected not applicable because it didn't hold a numerical value in the Likert scale. We did not include that in our analysis. And then for the waste disposal measurements, that was also analyzed using descriptive statistics. And we also, again, calculated landfill and recycling proportion to see which proportion was greater. And then I want to gloss over this real quick as well. There was no conflict of interest disclosed. We didn't receive any funding throughout the project, and the participation in all of the interventions and surveys were all voluntary. And then I'm going to talk about my results section. So we saw a 41% response rate for the pre-No Waste November survey, and then about an 18% response rate for the post-No Waste November survey. And then down on that list, I included, these were, in each of the survey categories, these were the environmentally sustainable behaviors that saw the greatest increase in mean. So for energy, it was biking, walking, carpooling, and taking public transportation at work. For the recycling category, it was leading or participating in recycling initiatives at work. For materials and supplies, it was serving on a purchasing committee that considers the environmental impact of products. And then for food and water, it was composting leftover food. And so here's another way to look at that data so you can see everything with the blue stars on top are all the things that I just talked about. And then this is a lot of data, but I wanted to include it so you can kind of see how robust the data was. And everything in orange is, again, the things that I talked about. And then for my second, for the waste disposal weight measurement results, after analyzing the data, we saw that there was a total waste mean of about 38.26 kilogram per week. And then there was a higher proportion of recycling to landfill waste 5 out of the 6 weeks. And then when the proportion of recycling waste was greater than landfill waste, on average, this proportion was about 44% greater. And table 2 here just sort of displays how robust the data that we collected was. And then here's another way to look at the data I just talked about. So the blue line represents the amount of waste we measured for trash bins. The green line represents the recycling bins, and then the brown line is the total. And then now I'm going to switch gears to my discussion section. So overall, at least one or more environmentally sustainable behaviors in each of the 4 surveyed categories had an increased mean. And the positive finding was that across the board, stakeholders, they consistently reported that they recycle paper. So recycling paper sustained the highest mean in both pre and post No Waste November survey, followed by recycling aluminum cans and glass bottles. And this finding was expected because this is kind of the fruit on the ground, and there was existing recycling infrastructure within the School of Nursing campus to support these behaviors. So that was expected. The greatest opportunity for the School of Nursing remains reducing food waste with organics recycling or composting, which is why it's such a celebration that the School of Nursing now has organics recycling. So this is a great one for all of us. And this remains the greatest opportunity because it had the lowest mean in both pre and post No Waste November survey, despite having the greatest mean change for the survey category of food and water. So I'll show you what that means here. So those 2 numbers that I circled in red, that's the pre-survey and the post-survey. So again, they have the lowest mean out of all the survey items. And then I'm going to talk about my limitations real quick here. So because this project used a convenience sampling approach, the results from the project are not generalizable, and there was also the limitation of having such a low sampling size. So again, neither the pre or the post New Age November survey had a response rate greater than 45%. And I also want to acknowledge the limitation that the invitation to participate in the campaign was limited to email invite and word of mouth. And then I also want to add that we were not able to directly measure the impact of the intervention of the sustainability dashboard because we weren't able to track in real time the frequency of visits and the utilization of the resources that were embedded in that dashboard. And we were also not able to establish reliability and validity for the waste measurements because we only collected one set of data each week. And that data is also not all-inclusive because we did not measure waste from recycling and trash bins in people's personal offices and their cubicles. And so I'm going to wrap this up by just re-highlighting that this quality improvement project aimed to help the School of Nursing mitigate its impact on climate change through addressing the gaps that I had talked about earlier. And I also want to re-highlight that nurses and higher education institutions, we all play such an important role in mitigating the human impacts on climate change through environmental and sustainability initiatives. And once again, the opportunities to mitigate the human contributions to climate change, so that all of that relies on ensuring that you have supportive policies in place, you're engaging people from leaders to frontline stakeholders, you're improving processes, and you're shifting practices. And so I want to end by just mentioning that for future quality improvement projects, some opportunities there includes examining barriers to adopting your environmentally sustainable behaviors, and also looking at incentives to support these behavior changes. And that is it. Any questions, comments, or feedback?
Well, big kudos to you for collecting some good data. Shifting behaviors in, I would say, a population that's already very aware of the initiatives and doing things proactively. I was just wondering, there had to be system barriers that you ran into because the School of Nursing is on the emerging edge of this. And what was your greatest lesson with that, with your project?
Yeah, good question. So the system barriers, when you say that, the two things came to mind, culture and policy. So the University School of Nursing had a great, very supportive culture that was very supportive of planetary health initiatives. So that was, I think the barrier for us is that because the university is so big, you found subset cultures within each school. So for example, the College of Pharmacy and the dentistry school might have a different culture. So that is the system barrier that if we're trying to do this at the university level, those are one barrier that I can think of. And the other thing is policy, is that because policy is language driven, stakeholders might sit at a table and spend hours drafting this really awesome policy, but how you and I interpret the policy from the leader's perspective to the frontline stakeholders, that might vary a little bit. And so I think that is also a barrier. And also that when you talk about policy, then you have to talk about the finance piece of it, which I didn't really dive into because I didn't have the appropriate time to do that work. Any other questions?
B, I want to commend you because I know for a fact you're going to be disseminating your work in the Creative Nursing Journal, which that issue that's coming out, I can't remember, sometime this fall, is the first entire issue of a nursing journal dedicated to climate change. So your work is going to be in that, which is wonderful. My question for you is, what do you carry away from doing this DNP project? What's going to stay with you, and how is it going to impact your career as a leader?
Good question. I think one thing that comes to mind is this idea of trust the process and trust the journey. Because definitely doing a quality improvement project, whether you're doing it at the small scale, the big scale, I think all of it there's so much complexity to the processes, and there's also a lot of processes. So I think trusting the processes and making sure that, and Shannon and I talked about this, like if I can go back and change everything, I wouldn't have really changed a lot because I really appreciated the relationship building and the partnership that went into to start planning, implementing, and evaluating this project. So I think that's what I took away is the people skills, the project management skills, and the relationship and partnership building skills, because those are, you can take those skills and apply it to any setting of work that you encounter.
I have a question. I noticed your measurement was weight of the trash and recycling. Is that like a evidence-based method to traditionally monitored
Yeah.
compliance or whatever it would be?
Sure, good question. So that recommendation came from Shanda, and when I talk to people, experts who are doing the work in the industry, what they usually do is they actually, so I did, bin to bin, what they actually do at the industry level. So I talked to somebody from Fairview. So what they do is they actually measure the total, you know what I mean? And so yes, because ideally, I think that's the most feasible way to measure how much waste output are we producing, is you measure the weight. But I think if you truly want to get into the ways, what you would measure, you need to track, okay, just because we put it in the recycling bin doesn't mean that it actually gets recycling. So if we truly wanted to be deep in the weeds and to evaluate, hey, is everything we recycle, is it actually recycled? You need to follow that trail. But for now, since my resources and time was limited, I could only measure the weight, and that was the fruit on the ground that we picked up.
Thank you.
Yeah, because I think there's something in the article now where China doesn't accept all the recycling output from the U.S. anymore. So now it's going to completely shift the dynamics and the culture here, and also a lot of processes in place in terms of we're promoting all these recycling behaviors, but I think the higher fruit to aim for is to prevent us from having to recycle these objects in the first place. You know what I mean? So I think that ties back to a lot of industry things and a lot of the economics part of our country. Yeah.
Thank you.
I had another question for you. Because you were working with systems and various people in different systems within this university and hierarchies and all of it, did you find any interest among other colleges and schools once it was heard that the school had this initiative with your DNP project? Was there other interest that was sparked by your project and raising awareness for the entire university?
Yeah, good question. That's a really great question, and that I think is also another opportunity to explore in future quality improvement projects. I think for me, because, and I chuckle when I say this, because every time I try to wrap my arms around this project, it got bigger and bigger and bigger. And so for my own sanity and with Radisson for the timeline that I had, I didn't venture down that road, but I think had I had, at least 2 years to do this project, and I had all the resources in the world, I think I would have ventured that way, and I would have built more bridges and built more partnership with other schools to see, because I think for the most part, climate change, learning about it, it's no brainer. It's been around for years. Like, it's not anything new. I think trying to find the solutions to address it is the opportunity that gets missed a lot, because we get so focused on this idea of it's not my responsibility, or because it's out of it's almost like how do I say this? Like, when you throw something away, you don't think about it anymore. But since I've done this project, every time I throw something away, now I always think about where does it go after I throw it away, and whether I put it in the recycling bin or I put it in the trash bin. And then I also think about how long will it take to biodegrade this product that I threw away. So now I start to think about that a lot, and it completely has changed how I shop, how I eat, how I buy clothes, and how I look at how I'm a consumer in this culture, this economy. Yeah.
Ooh, we need you out leading the movement.
Thanks, Jay. Go ahead, Charles.
So that leads me into another question. So you've identified some of these personal values that you have that lead you to make these decisions when you come to the trio of trash cans, and what other, as you were working with other people on this project that where you could see as like early adopters or the laggards in the process, what things did you identify as personality traits or like initiatives or drives that would drive people to make these decisions and care? And then taking that a step further is do you think in the future that kind of attitudes or behaviors can be celebrated or encouraged?
So I'm trying to understand your question. You asked, how did I identify the early adopters? What are some traits that they had? And then how do we take that learning and apply it elsewhere? Is that what you said?
Basically, so it's essentially saying you've identified things in yourself that cause you to want to do this. And you've also, as you've been working on your project, you identified other people that wanted to do this. Well, also, you've identified people that don't want to do this process. So how did you kind of differentiate between the two, or what are those key behavioral aspects that made people more willing to want to participate in recycling versus the people that didn't? And then how can you kind of capitalize on that positive momentum that you had with the people that were?
Good question. So I want to start by saying, by listening. When you listen to the words that people use, you kind of pick up how ready are they for change. And I think I was very fortunate that Shanna sort of introduced me to the group that was already the early adopters. So I sort of, through my partnership and networking with Shanna, she introduced me to a group of stakeholders within the school nursing who were already early adopters. So that was the foot in the door. And I think, and going back to this idea of listening, I always listen to see what questions are being asked. Because I feel like when people are not ready for change, you see it come through in the questions that they ask. And then I think if you can address those questions, from taking it back to the heart, the hand, and the mind, you know what I mean, the brain, and the wallet too. If you address all those pieces, if you can appeal to whatever they need to help them feel reassured, to help them feel like, hey, this is something that we can do. I think once you meet that in the middle there and address that piece, they're more likely to work with you towards the solutions. So I think a lot of it is almost like social in a sense, you know what I mean? You have to address that readiness for change. And I think, it reminds me of saying, how do I say this? Like, in a sense, it's changing people's behaviors, it really goes back to the heart, the mind, and the hand and the wallet piece. And so I think you just have to meet people where they're at, and you do it without shaming them, without judging them, accepting that this is where they're at. And there's a whole number of contributing factors there's a number of contributing factors that sort of play into why they're in that place. And I think not shaming or judging them or making them feel bad and meeting them in the middle there, and then finding ways to build bridges, to build that partnership, to move towards solution. I think that's the biggest, that's my answer to you, is how do you move people from a place of, oh, now I remember. So I think and I want to note Judy real quick here. So she always talks about polarity. So I find that when you look at any problems, whether it's climate change or diabetes or homelessness or anything that you can think of, I think people tend to live in two space. So they tend to live in where they fixate and they focus on the problems, and you have people who also see solutions. So I think what you need to do is get everybody on both sides to be in the middle, so they can appreciate the problems but also appreciate the solutions. And so I think that's my answer for you.
That's a great answer.
Yeah, thank you. Any other questions? Judy, we're doing okay on time?
Good, thanks, Steve.
Thanks, everyone.
Go ahead, taste.
Yes.
Next, it's my pleasure to introduce Travis Moore. Travis Moore is next. Okay, who is going to be speaking about his project that was done, and it's a classic quality improvement project, which looks at the gaps that were caused and the gaps that were causing quite a bit of trouble in a local hospital setting. So, Travis, we're very pleased to have you.
All right, thank you, Teddy. And also thank you for all of your guidance as I have endeavored on this project. So what I'm going to be presenting to you today is managing intermittent surges in the pediatric emergency department. This is a project that has been done in multiple hospitals across the United States and is now starting to be seen in other countries as well. So to give you a little background about the setting that this took place in. So this was a small academic children's hospital in an urban setting. It only, as a whole, has about 212 hospital beds that they're licensed for. And in the emergency department, they have about 10 beds, 2 of those being resuscitation based. So really, they only have 8 rooms that they're really operating out of. In an average year, this emergency department sees about 15,000 visits, and they have a pretty high admission rate for a children's hospital of 30%. Typically, the emergency department is staffed with 1 pediatric emergency medicine fellowship trained physician, as well as 3 to 4 nurses. And then they also recently started having what they call the moonlighter, which is a pediatrician that comes in during the evening shift to help staff and take care of the higher volumes of clients that they see in the evenings. So a little bit of background about the problem. So I'm sure that everyone is probably aware of the epidemic we're hearing about and seeing in the emergency department. And if any of you have had the pleasure of attending an emergency department, you realize that it is most of the time chaos. Waiting rooms are full of people. The staff are struggling to manage that volume and determine who needs to be seen when and perform proper triaging. People are upset because they're in pain, or they're worried about their family member or worried about themselves. So the tensions in these situations are usually pretty significant. In 2010, the CDC, or excuse me, 2009, the CDC released a report that showed a 25% increase in annual visits to the emergency department between 2003 to 2009. And that really connects to this kind of national shift that we're seeing of people, the local hospitals and the rural communities are starting to close down. So it's pushing resources to the more urban areas. In addition, we're seeing length of stays trying to be reduced. We're seeing procedures that used to be a hospital associated with a hospital stay are now being done in the outpatient setting. So all of these people are being pushed out to the community, but there's not necessarily a whole lot of resources in the community to make them successful in that discharge process. So because of that, now we're seeing that people are coming into the emergency department. We're also seeing a lot of emergency departments being treated more like a primary care because it's immediate. I have a symptom now, I can go to the emergency department, I can be seen tonight, instead of calling their doctor, making an appointment there, or their nurse practitioner, making an appointment there and waiting for a couple days. In addition, there has been a strong correlation in the literature of ED overcrowding associated with extended wait times, delays in treatment, increased lengths of stay, increased readmissions, increased costs, and overall decrease in patient and staff satisfaction. So the problem for this specific emergency department is through the winter months of January to April, they see about a 30% increase in volume of clients. Their wait time increases by an average of 45 minutes, and they usually have about a 10% increase in the number of patients who leave the department without ever being seen by a provider. Now this is compared to the other 9 months of the year. This surge in patients not only affects the department's ability to care for their patients, but also has negative effects on the staff morale as well as their PICR scores, which is their patient satisfaction. So, common solution to this problem, as we talked about, this is a problem that most emergency departments in the United States are facing. So a lot of departments have implemented what they call fast track areas. And so these fast tracks are separate lines of care to be able to care for clients that are lower acuity and be able to kind of create two paths. You have the sick path and the not as sick path. And so the not as sick path is often associated with faster turnaround because you're not needing as much testing, you're not needing as much expertise from the provider, so you are a low utilizer of resources, so we can get you out faster. These have been shown to improve throughput of departments, free resources for more acute patients and complex patients, decrease the wait times as well as the length of, LWBS, or left without being seen, and then as well as improve patient and staff satisfaction. So our intervention, we took into this department. Now again, we have 8 operational rooms. We had one room that we dedicated as the fast track room. So this fast track was dedicated to see those less acute complaints. So we could see those less sick kiddos in this one area. It operates in a much smaller space, so our footprint was much smaller. So to give you a little background on the emergency department, for those of you who aren't super familiar with it, is the traditional model is you start in the waiting room, you get triaged by a nurse, they determine how sick you are, then you go back to the waiting room. Then you move from the waiting room into your treatment room, which becomes your house for the next couple of hours. And there you are seen by the nurse that's taking care of you in the department. You're seen by a provider in that area. You're taken to other areas like radiology or laboratory, and then you're brought back to that room. And you sit in that same space, utilizing that same footprint for the entire time that you're in the department. So whenever you're in that space, we can't put anybody else in that space, and we've only got 8 of those spaces in the department. We can only see 8 patients at a time. So it dramatically slows down the process in which you move through the department, regardless of the number of staff members that we may or may not have available. So this space operates out of one room and is utilized to see a much larger volume than the other patients based on its design. So in this area, we deployed a dedicated RN and a non-pediatric emergency medicine trained physician. So we used a pediatrician. This model has been deployed with a variety of successes nationally, like we had talked about, yada, yada, yada. We're moving on. All right, continuing on in the intervention. So for staffing, this area used one pediatric emergency physician, one RN. We had a dedicated ED tech, and we had a dedicated registration tech. We're going to talk more about the registration tech and how crucial that person is to this whole process towards the end. And some background for this department. So they chose to upstaff by one physician while the fast track was open. They also decided to hire 2 contract nurses, so 2 travel nurses, to come in and fill all of the shifts specifically for this department. So they were staffed up by 2 people. The emergency department technician and the registration person were part of the regular PAR staffing levels. They were just dedicated from that PAR level specifically to this part of the department, which saw about half the patients. We utilized the consultation room. So I'm going to go back to the previous slide, and this is a picture of our consultation room. So you can see that we have wheeled in a computer, a cart, a couch, and then our little exam table / chair there. So this was ordinarily somewhere that we would bring patients in to talk to them families away from the actual patients, and we kind of converted this into a treatment room. And then we utilized, here's a picture of our little carts with all of our medical supplies that we kept in there. And then this hallway that you see is what we turned into our internal waiting room. So we utilized benches and chairs on one side of the hallway, and then on the other side of the hallway there was a little nook that we put some couches in. We could not put chairs on both sides of the hallway because the Joint Commission would not appreciate us putting things on 2 sides of a hallway and blocking a potential exit. So our little nook didn't count as a hallway, so we were golden there. All right, so we use a specific criteria to get to include people in our project. So we utilized the existing triage system, and they utilized the existing evidence-based emergency severity index to determine how sick the clients were. So the ESI, or the emergency severity index, rates it as 1 is most sick, 5 is least sick. And this system is largely based on, especially once you get to 3, 4s, and 5 level of acuity, resource utilization. So a level 4 would utilize 1 resource, and a level 5 would utilize no resources. So these are typically the patients that we want to see in that fast track area because we know they're not going to need a lot of resources, so we can push them through a little bit faster. However, we are in a pediatric population, so 1 resource can sometimes mean a lot more than just 1 resource. And so specific things that we ruled out were laceration repairs because they often take a lot of time. And this area was dedicated to reduce time, so we excluded them from this process. Clients needing enemas. So enemas are a very easy resource, however, they also take time. You have to instill the enema, you have to wait for results, not a fast process. Also, this is not something that you can really do in a room and then sit in a hallway and wait for the results. The next thing is clients needing splinting. Again, this is a longer process, especially when you have kiddos involved. You have to let set up, measure, let things dry. And then finally, we originally had 1-year-olds with a fever in our area, but then we realized that the vast majority of them required further intervention. So if they didn't have an ear infection, then they needed more resources. If they did have an ear infection, they were super easy. And so we learned that more often than not, it wasn't an ear infection, so therefore we decided to exclude them from our process as well. So as you can kind of see, this was a very iterative process. We started off with something, we would run a PDSA cycle and say, okay, these 5 things didn't work, now let's regroup and redo this process different. So it seemed like every day something had kind of changed just a little bit. And there wasn't a clear, like, we're going to do this for a week, and then we're going to change it, and we're going to do this for a week. It was just kind of like a threaded process. All right, so overall, the process, patients who met the criteria were moved into the fast track waiting area. So the triage nurse would take them, triage them, determine they were a 4 or a 5, and they could be included. Then they would take them back to our internal waiting area. The fast track nurse in that area would then move the patient from the internal waiting room into our exam room. They would do a quick assessment, tap the physician, and the physician would go in to do an assessment. When the physician came out, they would again bring the patient with them and ask them to sit in one of the open waiting area seats. The nurse would then see the physician was out, and we kind of leapfrog. So the nurse would clean the room, grab the next waiting patient, put them in the room, do their assessment. In the meantime, the physician is able to document their assessment, provide any orders. By the time the nurse was done with the next patient, the physician went in. The nurse was able to see what orders had been done. Sometimes those were just disposition orders, so it was then printing discharge instructions, giving the client the instructions and getting them out there. Sometimes it was more sending them to the lab or giving a medication, something like that. So it's really awesome leapfrog process that we came in. And when you had a really good doc and a really good nurse, it worked really well. It's really highly dependent on that, we found. So anyway, the things that the clients would wait for in the hallway were mostly disposition, waiting to get discharged, test results. So we either did a flu swab or a strep swab or something like that, and we're waiting for those results, or sometimes urinalysis, and then registration. The fast track area was open every day from 5 p.m. to 1 a.m., which were determined to be the peak census times for that department during that time of the year. So, measurements. First one, patient satisfaction. We utilized 2 questions on the NRC Picker scores, and so this was saw provider in a timely manner, and would you recommend this facility? These were measured pre and post. We took the scores from the average questions from 2017 and compared them to 2018 to see a percentage of change. The next thing was average length of stay in the department. Again, we measured this pre and post. We collected this information from Epic, their electronic health record, and then the length of stay was measured and averaged for 2017 during the winter months of January, February, and March, and then again in 2018, and then we compared those for percent of change. Finally, we did the same thing for left without being seen. Same exact process, collected from the EHR measured in 2017 compared to 2018, thus percent of change. So, results. In our study period, in 2017, the department saw 4,523 patients during that 3-month period. So again, we said they saw 15,000 patients a year. So that's a large chunk of their patients being seen in the first quarter of their year. The 2018 year, we saw a 2% increase in the volumes. 2% decrease in the volumes. So we actually went down a little bit. We were anticipating scaling up a little bit, but we actually scaled down a little bit, which was kind of unexpected. And then for our patient satisfaction, we saw an overall 2% increase in the response to saw provider in a timely manner. So patients were marginally feeling like that they saw the provider a little bit faster. And then a 6% increase in would you recommend this facility. So a little bit better of an increase in would you come back. Now, unfortunately, we didn't have as good of results on the other side of our data set. So we actually saw, we were aiming to decrease the length of stay. However, we saw increased length of stay by 9% between 2017 to 2018. So 2017, 240 minutes, average length of stay, 262 minutes in 2018. Now, there's a caveat to this information. We were not able to identify in our data fast-track patients versus non-fast-track patients. So there could have been more sick kids in the hospital, which caused the admitted patients to wait in the emergency department, thus increasing length of stay. However, maybe the fast-track people were actually seen in a shorter length of stay. We really tried to isolate that data, but there was really no good indicator we found that did they go to fast-track or did they go to the regular emergency department. So we weren't able to really parse those apart. So that's kind of a confounding variable in that data. And then our left without being seen rate went up by 120%, which was also very shocking. However, when we look at this, in 2017 there were only 3 people that left without being seen. And then in 2018, there were 7. So again, the numbers are so small that any change in that creates this dramatic percent of change. And so, especially when the numbers are that small, it could be one night that was crazy, and 7 patients left in one night, and that was the only night that they had the problem. Okay. So a couple of variables that really affected our outcomes. Oops, wrong direction. So here's a graphic that just demonstrates what we just talked about. So we saw an increase in seeing your provider in a timely manner. We saw an increase in recommending facility. Both of those were positive changes. And then we also saw an increase in LWBS as well as length of stay, which were negative increases or negative changes. So let's talk about this a little bit. So we had a lot of enthusiasm from all of our teams. Everyone was super engaged. Everyone was excited about the process. We had complete buy-in from just about every single one of the staff members. They were excited to find a different way to kind of offset their burdens. A lot of the anecdotal information that we got from the team is that it was hard to go from a mindset of taking care of a critically ill child to moving your mindset to taking care of someone that is less sick, and you're constantly questioning yourself, are you missing something? Is something else going on here? and waffling between those two mindsets was a little bit challenging, and it also made them feel just a little bit jaded towards the person that wasn't as sick, because they had to split their time with someone that was a lot sicker in their heads. So it created this kind of almost moral conundrum that may or may not have affected their care. So they were excited to see kind of separate lanes, and if they could get in the fast track mindset, then they were, that was their job there, was to take care of the less sick kids that day. This kind of diminished the challenge. Oh, we talked about that already. Okay, that we all talked about. All right, so a couple of limiting factors or learnings that we had. This process is highly, highly dependent upon triage. And so this department only had one nurse at triage, and we also found that it seemed that patients like to arrive in clusters. So there would be 3 or 4 patients that would come in at the same time, and there's still only one nurse. So that is kind of a limiting factor, allowing people, even though there was nurses in the fast track ready to accept those clients, there was nobody to triage them to determine if they needed to go to the fast track area. In addition, when 5 patients show up at one time, the nurse has to determine which client looks the sickest, and they're going to be the one that's seen first. So oftentimes those are not people that are coming to the fast track area. Those are going to be going to the irregular emergency department, and the ones that are going to the fast track area, while they may have checked in first, are often seen last out of the people that come in. And so that also increased our length of stay for that department. And then finally, it was highly dependent upon the patients being triaged appropriately. So sometimes you have a mistriage where a nurse felt like the patient wasn't as sick as maybe they were. And so during the provider assessment, they were determined to be actually much sicker and needed things like IVs, labs, lines, that sort of stuff. And so then they had to be moved out of the fast track area, which took some more time and utilized resources that may have been better utilized in other ways. Our next big learning was laboratory testing. So many of the complaints during this season, it's flu and RSV season, so there were respiratory illnesses and fevers. And so we were doing RSV and influenza testing on a lot of patients. Unfortunately, at this hospital, there was no point of care testing for influenza or RSV. So therefore, all of these specimens had to be sent to the lab, which is a little bit more of a process. And the analyzing machine that ran these labs took 47 minutes to complete the test. So because of that, anytime we ran a flu test on a patient, that automatically increased their length of stay by 47 minutes. Not to mention the collection time, labeling time, sending the specimen, and how long it sat in receivings in lab before it got put on the analyzer. So there was a big variable. We really tried to hone in on this challenge. First of all, through education. So the pediatric emergency medicine physicians met with and kind of had like a discussion about the utilization of influenza testing and when it's actually indicated versus not indicated or useful. So a lot of times parents would want to know, I want to know if he's got the flu. Well, it doesn't necessarily change the parameters of what we would treat. So why are we ordering a test even though we might not be treating something for it? Especially this long test and also expensive test. So that kind of changed a little bit of the mindset with the providers. However, everyone is very hypersensitive to patient satisfaction. If the patient asked for it, it likely happened. So that was the big kind of limiting factor when it came to the lab testing. And then the registration process. This was our first learning on day 2 that we really did not think about registration in the fast track process. We thought about the medical team, we thought about the nursing team, we thought about the tech, we thought about the supplies, the laboratory, and most of the other things. But we didn't think about registration. We were just, it just happens, And we realized that, so at this hospital, the patients cannot be seen by cannot be registered until they've been seen by a provider. So they have to be seen first. So traditional process is you get checked in, you're registered when you check in, then you see the provider, you get discharged, you go home, it's no problem. Well, this facility, we had to do it a little bit different, and so they had to be registered after the provider. So on a general note, this department has kind of a struggle trying to figure out when to register the patient because there's no indicator on the EHR of if they've been seen by the provider yet. And so it was this guessing game of, well, they've been here for 15 minutes, maybe they've been seen, the registration person walks back, no, they haven't been seen, they walk back out to the front. And so we decided to co-locate one of the registration staff with our team in the fast track so that all 4 of the members would sit in the same space so that we could physically see where each other was without actually saying anything, just the visual indicators allowed us to know what was going on in the department. So then the registration person could see the person that just came out of the room, they would immediately know that they were ready to be registered, and then they could be registered, and it increased the the flow of our process just dramatically. Conclusion. So this model, while it didn't necessarily demonstrate its huge success in the data, did feel like it was a pretty good project, and it was actually re-implemented again this year at that department. This project really demonstrated the kind of efficiency and effectiveness in combining two different models. And one of them being the fast track model, the second being the vertical care model. And so that vertical care model is the fact that there was no bed and there was no room, and they were only in that exam room for a moment to get examined by a provider, and then they move into the external waiting or internal waiting room. Now, what this process does for the patient and the family is it makes them feel like they're moving along a path. So it makes them feel like they're constantly doing something. They're not waiting in a room. Now that we're waiting again in the same room, it's like, oh, well, we've moved to the next space on the continuum, so we must be getting closer towards the end of our process. And so it keeps their minds feeling like they're moving, so it decreases their irritability and their with waiting. In addition, it keeps people from putting down roots. So you get into a room with a bed and a television and everything's going on, and you unpack the entire diaper bag and all of the toys and everything is spread out now, and now it's a 15-minute process to wrap all that stuff back up. And so it prevents a lot of that from happening. They limit it to one toy or what they need out of their bag because they know they're not staying in one place for very long. So it also increased the throughput from the department as well. This really was a really good practice in having the teams participate together. At this emergency department, there is a separate room for providers and a separate area for nurses. And so while they're next to each other, there's like this big glass wall between them. And so they're really two separate teams. And so one of the things that we did is co-located, let me go back to there it is. We co-located all of our team. So in this picture, you can see this was the provider's seat. This was the nurse's seat. There was a registration person here on a mobile workstation. Directly behind the nurse, and then there was an ED tech that was sitting right here, not pictured. So all four of us were elbows length away from each other, and it was super helpful to be that close to the provider, as well as for the provider to the nurse, because then while they're doing their documentation, they could transfer information verbally. We physically knew where the provider was. The provider physically knew where we were. The registration provider knew where everyone was. So it really made for that kind of seamless transition that you don't get if you can't actually physically see. You're guessing where is the provider, which room is he in, and you're trying to peek around curtains and figure out where the provider is. So the project aim was partially met through marginally improving patient satisfaction. The aim of decreasing length of stay and left without being seen, unfortunately, were not met. We feel like the low volume of patients was a confounding variable, and we would recommend in future projects that it be performed again at a larger facility, having larger volumes. That way, those with larger ends, you have less variability when you have like a single bad day to really offset your data set. I want to give a special thanks to Teddy Potter, my project advisor, as well as Jen DeWalt, who is the director now of emergency at that facility. And then the references. Any questions?
Travis, I wonder if did you take the time to maybe like take out the visits, like the flu visits, that you knew laboratory caused the extended wait times, to see if there was any improvement in times? I mean, with all the extra time you have in your life, right? I just wondered if you could see like, oh, if we didn't have this,
Right.
we weren't waiting for lab, we did make an improvement.
So originally, I was going to partner with the pediatric emergency medicine team, and we were going to actually do more of targeted focus on like what specific labs indicated a longer wait time, and then looking at specifically outcomes to see if they did that make an effect? Did they have a repeat visit and so forth? And so we started to get really in the weeds with a lot of that stuff. When I brought in, the physicians were like, "Oh yeah, we want to partner with you on this study," and I was like, "Well, it's not a study. It's a project improvement, a quality improvement project." And they're like, "Well, it can be both." And I was like, "Okay." And so it was like, when we had a meeting about it, and then I got an email from the three providers that wanted to join with like this massive data list of things that they now wanted to control for in the project. And so we started to move forward with that. And as we got into that, we discovered that we were encroaching on territory that we shouldn't be doing in a DMP project, so we had to pull back.
Gotcha.
So it was really interesting learning about working with two different, like a research versus a quality improvement project, and where the line in the sand is. So to answer your question, no. because we backed off and we tried to scale back and keep it within the scope of a DMP project. But we did think about it.
Yeah.
Yes.
I had a question about your leapfrog approach. I love that comparison. And did you have a train the trainer? Did you actually train your nurses? Did you have an opportunity to select and hone those skills to be able to make your model work?
Yes, so this was isolated to 2 nurses, so that was like reduced the variability in practice dramatically. Now, even between those 2 nurses, there was a lot of variability in practice. And also what we found is that with the physicians, we had a group of 5 physicians that we worked with, and while we did do training and with both of the nurses as well as with the physician team, there's a lot of ingrained process and that ER mentality that we really had to overcome. So it depended upon, one of the nurses was really good about grabbing the physician by the wrist and saying, let's go, and the other one was not. And so because that leadership with the nurse really moving the process and facilitating the process was key in making this a much more successful model. And one of the biggest challenges we had is they really liked being behind the glass. And that was really one of the biggest barriers, is we didn't know where they were. We'd look in the room, they weren't in the room, they weren't at the desk. Are they in the bathroom? What's going on? You know, we got patients to see. And then it really slowed down the process when you didn't know where each of your team members were. And so then you find them behind the glass chatting with their colleagues, and it's just like, all right, come on, let's go, was kind of our process. So that was something that we probably should have focused a little bit more on, is how to coach the provider and making sure that we're staying on top of these things. Now, some of the providers were coaching the nurses, and we're like, all right, let's do this, let's get it going. And then the nurse would have a little hard time keeping up with them. But does that answer your question?
Yes.
Okay, thank you. Okay.
Yeah, a lot of this could be human factors design work too, so I hope you'll consider publishing in those fields, not just the nursing literature. But my question, because I know this quite well, is really about you. You've been a manager and a problem solver like much of your career. What has the DNP done that added or changed your traditional problem solving technique?
I would say that the DMP program or the DMP project?
The DNP program.
So that's broad. It is. I would say that it has changed it in such a variety of ways. Because I think the biggest thing is it kind of takes blinders off. Traditionally, when you get into a role, you think like that role thinks, and you think in that profession in the way that that profession thinks. And then you kind of assimilate to the culture of the facility that you're working at, and you solve problems like they've solved them before, and like your other colleagues in other departments, they solve them. And I think that in the DMP project, we've kind of broken those blinders off, spun you around a few times, and now you just kind of like have a different understanding of how to incorporate other teams, or understand just the knowing that I know that there's someone out there that thinks in the complete opposite perspective of how I'm addressing this problem. So how can I find that person? Who is that person? And how can I partner with them so that I have a well-rounded understanding of what the issue actually is? So I think that it's making me step back from really problem solving and more into problem discovery. And to see this is a symptom, but is it the problem? And is there something else that's causing this to go on? And then in addition, it gives you a broader understanding of how many people are involved, and it's kind of the theory of complexity. And you think that maybe this, linen hampers in these rooms are constantly full, and it has to do with the lazy CNAs that aren't emptying it, and it could have something completely different to, the bags, we only have 10 bags in the room, and it has something to do with, supply management, and that has something to do with, we were only able to get, this number of bags, or we didn't get them on sale, or they only had purple ones instead of blue. So it really makes you kind of like go upstream to see what could this be a symptom, or is it actually a problem? So it makes you think, I think, more holistically about a problem. It also really helps you discover the resources that exist outside of what you know about. So you get into a facility, into an organization, and they're very good about demonstrating what they can offer you and what they have made available to you as a leader. And I think that the program really helps blow that open by saying, this is the world, and these are the people, and all of them are at your disposal. And so you learn how to find those people, and then before that you really learn who are those people? Who do I need to be looking for? Who's not sitting at the table that should be sitting at the table? And really identifying those kind of key players.
You sound like Dr. Travis Moore.
Well, I soon will be.
Nice job. Yeah.
Oh man, you're good.
Well, it's with great pleasure that I introduce you to my advisee for the DNP project, Anna Burke, and she took a look at Team Steps and an innovative way to bring it forward in a maternal child center and in the patient area.
Yeah,
Take it away.
awesome. I would also like to thank you, Judy. I really appreciate all your help. You really do help land the plane. I'm a very big, I see everything and I forget like how important the details are, and you really help me get there. So, thank you to you. Like Judy said, my name's Anna, Anna Burke. I'm in my third and final with these two lovely people here, and we're graduating in May. I'm very excited. I have my background's in labor and delivery, so this project fit very well with me. And I was able to work at the facility do my project at the facility I work at, so kind of knowing the ins and outs was helpful too. The setting was in a suburban hospital. We do about 2,500 births a year. And this picture is kind of giving the why fetal heart rate tracings and why Team Steps. So unfortunately, the facility had 3 adverse events within the last 2 years. And I think this picture really depicts the importance of the work and why we were doing what we were doing. Adverse events are not great for anybody, particularly patients, but this is the impact that as nurses we want to stop. We want to stop these. You can see how sad these people are and how really an adverse event can impact the morale, can create moral distress and frustration. So that's why we went with Team Steps, because we know that Team Steps can help build teams and improve quality to avoid having these adverse events. And then we'll talk a little bit more about why fetal heart rate tracings, but mostly with the root cause analysis and with the leaderships, that's what we decided would be the most impactful in the time frame that we had. So what's a fetal heart rate tracing? This is the bread and butter of what we do. You can see the picture there. That's what we look at whenever someone comes into the hospital to see how their baby's doing and how frequently they're contracting. Our nomenclature comes from these 3 organizations. The American College of Obstetricians and Gynecologists, the Society for Maternal Fetal Medicine, and the National Institute for Child and Human Development. They kind of decide what we do when, how we do it, give us the terms, change terms, and give us the structure of what's best practice. So 3 categories. We talked about it's the category 2 tracings. Category 1 is what you see over there. And as a bad labor and delivery nurse, I'll say, this is a happy baby. This is how we say it. And this is part of the problem. We don't really use the definitions we're supposed to. We're getting away from that. But a category 1 tracing, 99% of laboring patients will have this tracing at some point in their labor. I call a doctor, I tell them the fetal heart rate is a category 1 tracing. They'll go back to bed. They'll wait for me to call them and tell them something else is going on. Let's skip category 2 and go down to category 3. 0.1% of tracing. So a very small amount of fetal heart rate tracings will actually have this. This is easy. We know we got to go to delivery now, whether they're having a vaginal delivery right now or they're getting expedited to the operating room. Those are really easy. So category 2, which 84% of fetal heart rate tracings will have in labor, is when we have to decide what to do when, how to do it. A lot of that comes from knowledge and how long you've been there. So being a seasoned labor and delivery nurse, sometimes I don't necessarily know exactly what I'm saying to a doctor, but I'll just say, I don't like the trace and I need you to come down. And being that I have some great relationships, that works well, but we know that there's new doctors and there's novice nurses, and that doesn't always work really well. So when we have that culture of not using the terminology we're supposed to, we can really have the gap of care when we have that 84% of tracings that they're not being communicated correctly. So what do you do with the category 2 tracing? It's a lovely algorithm. Unfortunately, the root cause analysis showed that like 90% of the nurses had no idea this existed. Now if I didn't look at this, and having done this for a while, I could probably do the right thing most of the time, but I can imagine that sometimes I wouldn't, and a novice nurse may not make these decisions the way they're supposed to or in collaboration with the physician. We also found that the majority of physicians knew about this, but they didn't know that they were supposed to be talking to us about it. So through the root cause analysis, we realized we're going to work on fetal heart rate tracings, and we're going to make sure everybody knows this, and they know it inside and out, and they're going to be using this when they communicate to a physician. I'm sure most of you are familiar with Team Steps. Having had this training in the DMP program, I suggested this with my leadership team, and they kind of agreed this is the route we should go. So just a quick background of Team Steps. It was created by the Agency for Healthcare Research and Quality in conjunction with the Department of Defense directly out of when the landmark study to Err is Human came out. So we know that we make medical mistakes and our patients suffer. So they developed this program for the interdisciplinary team to use, and they came up with this. You can see this little triangle here. So it has the 4 pillars: situation monitoring, leadership, communication, and mutual support. Those are teachable skills that we can teach the interdisciplinary team to have higher performance, better knowledge, and better attitudes within that interdisciplinary team. So we're trying to increase the awareness, we're trying to clarify roles and responsibilities, resolve conflicts, and eliminate barriers to quality and safety. We chose to work off 2 of these. So communication, we took the SBAR tool from there. We were going to really hone in on the SBAR, and then a mutual support tool, which is the CUS acronym that we'll talk about a little bit more and why we used it and how we used it in our simulations. And I think this is kind of the overarching goal of what we were trying to do, producing the effective team. So awesome individuals are great, but if you have, as in a labor and delivery setting, it's a really interdisciplinary team that we depend on. Physicians are often off-site, so you have to be able to communicate well to make sure your outcomes are going to be what you want. So I just took this quote directly from the AHRQ website because I think it really epitomizes what we were trying to do, producing the highly effective team, optimizing information, optimizing people and resources, and achieving the best clinical outcomes for our patient. So that all sounds really great. Well, how do you do it? There's so many tangible things that we could pull in, and so what we did is we broke up this project into 3 phases. So in project development, we figured out who was going to do it, what we were going to do, when, where, all that stuff. We sought out some buy-in and some support. And the pre-TTPQ, I just want to talk about that. So we did a pre and post. That stands for the Team Steps Teamwork Perceptions Questionnaire. So it's like 30 questions. We modified it to pull appropriate questions for using a communication and mutual support tool. So it was only 8 questions long. So really quick, that was sent out to all our nurses and providers. The second phase was actually doing the simulations. We used the Team Steps simulation methods and the methodologies, or with the SBAR and the CUS. And then the third phase was doing after the simulations were done, was doing a post-TTPQ to see if those had changed, those perceptions had changed, and then looking to see if we accomplished what we set out to do. We'll talk a little bit more about some of the outcomes that we were looking at as we get to them. And just for background, that simulation, it probably took about 3 to 4 weeks to get them all, as many as we could, done. And the whole project, it started in May and wrapped up probably November. So that was the time frame. So phase 1 planning, what did we do? I met with our leadership team. That's when we talked about those RCA, the root cause analysis, what we wanted to do. We decided, yep, we're going to do Team Steps. Yep, we're going to really focus on that Category 2 tracing because that's going to impact some of our outcomes. And especially because people didn't know what it was, we realized that was a really big gap that we needed to fill. Baseline audits, that was one of our outcomes. So we did an audit form that was created by my community partner, Jane Sublet. She's the nurse educator on our unit. That was dedicated to the charge nurses. They had informational meetings with them. We had informational meetings with them. We sent out emails that kind of explained, hey, if you can catch an SBAR when you see a Category 2 tracing, write it down. Did they say the algorithm? Did they give a full SBAR? Did they give a recommendation? We left that in the charge nurse's hands. You won't see any results on those audits because we only had about 5. A learning was that it's really hard to capture those moments because charge nurses are very busy, and maybe a self-audit would have given us some more data, but the number was so low that it didn't really tell us much. And then we sent out that TTPQ to nurses and providers, which included 5 physician groups and 1 midwife group. Also in the planning phase, we met with our perinatal quality team, which was just a group of providers to really get their buy-in, and it was great. They were on board. They thought their SBARs were really kind of all over the place. You got great ones sometimes, not so great ones from others, and that people really weren't giving the same information every time. So they were on board. They agreed that this is something that needs to be done. So that was the planning phase. Some of the other, to get the information out to nurses, there was weekly meetings, there were staff meetings or weekly announcements, staff meetings that we have every couple months. So in the time leading up to it, there was talked about that would be happening. And there were flyers in the bathroom, because I think that's the best place to give information. Excuse me. So phase 2 was the actual simulation. I just put a little joke up there about communication, because it's really important, and it can be so easy. It's the things we do all the time. But if we're not communicating, we can see that we can have things happen that we don't want to happen. So it was the simulations. It was 3 people in the room, myself, who was facilitating the simulations, a nurse, and a provider. They all got the same fetal heart rate tracing, which was really enlightening to see that I could meet with 50 different people and not have it done the same way every time. I would say a majority of it was pretty similar, but there were some that I really had developed an empathy for providers who might not get the picture that I was seeing every time. So that was a great learning for me. So we talked about the SBAR. They were going to give a great SBAR. And then CUS. That's the second thing we implemented. And we kind of talked about it in the emails and in the staff meetings, that what CUS was. So CUS is an acronym that stands for I'm concerned, I'm uncomfortable, I think this is a safety issue. We put this out there because we thought we might get some feedback of, well, the doctor doesn't listen to me when I give my SBAR. Why would I give a recommendation? They're not gonna listen to what I have to say. It doesn't happen often, but we know that there can be those isolated incidences. So we wanted to provide staff with a tool where they could feel more empowered. We designed the simulation that I would let the provider know, like, give them a tough time at the end of this one. And so we wanted, without prompting, I wanted to see if they would use that CUS acronym. They didn't always, but then with a little bit of a reminder, they would say, oh yeah, I'm concerned, I'm uncomfortable. I'd like you to come in now. So that was a great piece that we added into probably about 75% of the simulations. And I say 75% because having worked there, I had a little bit of a leg up. I knew which nurses would say that without me telling them they should, and I obviously didn't tell them to do that. But the nurses that I felt maybe need a little bit more assertive training, that I would plug that into their simulation. And we continued the audits, but unfortunately, our volume wasn't a lot. So the next phase is the results, which I'm really excited about this first one. Since implementation, we've had 0 reportable events to the Minnesota Department of Health, which that's about 9 months. And if you think in the past 2 years prior to that, we had 3. So, and I don't want to discount that. I know that are reportable events, and there's a lot of confounding factors. If there was a silver bullet, we'd have no adverse events. If we knew what stopped adverse events, they wouldn't happen anymore. But I do think that it's important that we know that we're not having any more adverse outcome, or haven't had another one, and that the morale is better. And I can say that that's a really hard thing to quantify, but working there personally, it feels better to not have a reportable event. So that TTPQ, so these were the 8 questions. The pre-surveys in red and the post-surveys in yellow. Our goal was to have a 15% increase on all the questions. It was on a 5-point Likert scale, so anybody who reported always, almost always, or always, they were put in this category of that they were in the 90%. So one thing I didn't consider before was that maybe there wouldn't be room for 90% improvement. So we only had 3 that were actually a 15% improvement, but you can see that we do have some great. We did have some great survey results to begin with. So this is information given to you timely? Are you given the relevant information you need? Are you notified about potential complications? Are you cautioned in dangerous situations? When somebody feels there's a safety issue, are they being challenged? Or do they challenge the person who's not listening to their concern? Are we using common terminology? do staff verify information, and is there a standardized handoff? So my biggest takeaway is that we saw that increase in the challenging others, which I feel is a direct relation to the CUS tool. So if you felt like you weren't being listened, that you were going to go ahead and challenge. So for outcome-wise, we only had 3 out of 8 questions that saw that improvement, but I think the data shows that we're doing pretty well in some of the other areas. This is my saddest one. So the goal is to have 90% of nurses. We hit about 77%. And I think that was designed because in the development phase, we didn't want to have overtime. We didn't want to have staff come in extra. So it was me going to the unit on off shifts and trying to catch as many people as I can within that month. Some people just couldn't be met based on their patient was busy. The day I went to see them, they just couldn't get out. We took out for LOAs and things like that. So it really was only 80 or 77% of the staff, nurses that were available. Our goal was to get 1 provider from each group. We got 1 midwife from one of the groups, which was great, and no doctors showed up for any simulations, which was kind of disappointing. 1, because we know that they're a huge part of the interdisciplinary team, and 2, there was such great buy-in that I couldn't believe that nobody volunteered their time to show up, despite multiple emails, despite talking to them on the unit. And that was a big learning for me. So I realized buy-in doesn't equal commitment. So what I should have done initially, when I was in that meeting where everybody was so excited about it, I should have got contacts and said, hey, I'm going to talk to you this time, or will you be willing? And really got that commitment ahead of time, because unfortunately we didn't meet our outcome there because we didn't have any doctors show up. So what are we going to do to make sure that this project is sustained? The exact same tracing, the exact same questions, the exact same audits are put into our new hire orientation. So every nurse that comes under a unit is going to look at that tracing, is going to sit down with our nurse educator and give the appropriate SBAR that they should be giving. I've noticed a change, and this was one thing that we couldn't quantify, that charge nurses are now paying more attention to some of our novice nurses and asking them if they need help with an SBAR. We have little SBAR reminders on our phones that charge nurses are saying, oh, you calling the doctor about that one, what's your SBAR? And some nurses are practicing with some of our newer nurses. And then our peer-to-peer sharing stories of the cuss, which has been really great. So I've heard a nurse come up to me and she's like, I cussed at that physician, Anna. I told him I was concerned and he wasn't listening to me and I was worried about the safety, and you know what? He showed up. So that's happened about 3 or 4 times. So I hope that's not an isolated 3 or 4 times, that there's many I haven't heard about. But it was really awesome to see that our nurses were feeling empowered. So this is my final slide and my tips for organizational leadership and what I think this means for nurses. I think that Team Steps training is a really underutilized tool that can improve the quality and safety of patient care. The data is there. There's multiple research studies that show that improved or simulations with teamwork in the interdisciplinary team can improve the quality and safety of patient care that we deliver. And I think that a shift is needed, that we need to invest not in the individual, but in the interdisciplinary team. So it's great to have nursing education hours where we send nurses to different conferences and to do those things. But I think pulling people together and having the interdisciplinary team develop together is what's going to change our quality metrics. That's it. Any questions? I've got lovely references on here on that side. Yeah, Teddy.
I have an invitation and a question. The invitation is, I hope you'll consider doing a poster for the American Hospital Association Leadership Conference. They do that every year,
Yeah.
and a lot of them are applications and team steps.
Okay.
I think it would be a wonderful way of just demonstrating to all the attendees
Yeah.
how this is used. So my question is, where now? What are your plans in your hospital for being involved in this work, or are you choosing a different topic with your DNP to move in, or whatnot?
I've been really working on our business case. I'm focusing on, for the business case, just the labor and delivery unit. But I initially started with, and I realized when I was trying to pull in the financials, I didn't have the resources to pull in the financials I wanted. Would be like a hospital-wide training. Like every unit educator has, you've got a year annual thing. You've got to do a team step simulation every year. It's just like any LMS you got to do. You need compliance. So if you don't do it, you don't work. You take your badge. So I think, you know what I mean? If you don't finish your learnings, you're taken off the schedule. So I thought, what if we did that for simulations? And what if we picked a high risk thing from every unit and did that annually? Worked on these concepts, works on this terminology, and really built up that interdisciplinary team. I don't know, it seems like something that is worth investing because when you look at the numbers of what an adverse event costs to education, it's significantly different. It's not, when we talk about return on investment, it's more of a avoidance cost, but I think that it's a great thing to avoid because when you look back at that picture, like that's what is painful in nursing. That's what's really hard. There's other things that are hard too, but you know, as labor and delivery being the happy place in the hospital, that's what's impacting. Yeah. Thanks, Steady.
What would you say is the easiest part of this project? What was came the most effortlessly from your implementation process?
I loved doing the simulation. I was like, I could run the sims. This is great. It was really, I loved how it really opened my eyes to what, I mean, I think we give sometimes our physician partners a hard time, and I was like, dang, I would be angry if I heard that SBAR too. I'd be really mad. I would yell at you in the middle of the night. Not as what were you saying? That doesn't make any sense. So that part, I felt like I was being a traitor to the nursing profession, but that was really awesome to see, and it was fun to hear all people interact and to watch people learn, and to hear somebody say, "Well, I didn't know how to do that. I didn't know I should be doing that." I really liked that piece. I thought it was fun. It was fun to see the staff that I work with in a different light. So that was easy. That was fun. The other stuff was like planning and doing the whole detail stuff that Judy's really good at. That stuff was hard.
I feel you.
Yeah.
I had a question about the providers because obviously you didn't have the buy-in with the physicians following through.
Yeah.
Even though they might have expressed interest when
Yeah.
you presented your project. How about the nurse midwives? Because actually I have done continuing education with advanced practice nurses, and sometimes some are resistant to doing this with nursing staff. They're providers.
Yeah.
I'm just wondering about your experience with APN.
So we recently added our midwifery group probably 9 months prior to me doing this implementation. So they were in a lot of turnover, but the lead midwife, she was all about helping me. And she wanted to come in and be there multiple times. And she was there for multiple simulations. She offered up some of her newer staff who couldn't make it to some of the simulations, but emailed me and tried to be there. So our midwife counterparts did significantly better than our providers. And I think we have a really great group of midwives. So I can't speak to everyone, but they were invested. They were ready to help. So that was great. Yeah.
I have another question about the simulation. Is this something that could be done in the future, even if they can't be in person, doing the SBAR over the phone?
I think so. So what I did was I just took a nurse when I didn't have a physician. I just took a nurse who's already done the simulation and said, here's what I want you to do, and which was kind of cool for them to see them in that role and for them to be like, oh, it is kind of hard to listen to this, So it was a lot of learning. Granted, it wasn't the way I planned it, but I think it can be done because in the instance that I didn't have somebody there, I acted as a provider and the facilitator. So it can be done. It's pretty, we called it a mini simulation because it was really quick. It wasn't like the simulations that are videotaped, you debrief after, you watch yourself. People were really scared of the term simulation when we talked about that. They thought they were going to be videotaped. I'm like, I'm not taping you. It's just quick. It's just what's an issue that we're dealing with right now. Let's do it and let's figure out where the gaps are. So it was a good learning. It can be done pretty quickly.
So it sounds like the value for the nurse is being able to practice using these tools of CUS and SBAR, and so they can become comfortable with that.
Yeah.
From the provider's perspective, what was sold as the value to them, other than being the person?
So what they spoke to when they were in that meeting was that they wanted to be able to give feedback about the kind of SBAR they wanted to hear.
Oh.
So they thought, well, I can be there and I can explain what's good and what's not. And so that's why they were so excited about it. I don't need a 3-minute SBAR. If they're rambling, what do I do? And I was like, well, you could just ask them to give you an SBAR and say, what's the SBAR? If they're rambling, what's the background? Prompt them. So it was an opportunity for them to practice speaking to a nurse when they weren't giving them the info that they wanted. So it was it probably was more beneficial to the nurse, but I also think sometimes physicians are frustrated that they're concerned that we're not doing something that we're supposed to, or they could throw out a customer. I'm concerned you're not turning up that Pitocin. Concerned and uncomfortable. I'm uncomfortable that, she's getting a fever, and I think this is a safety issue. I think because we're dragging our feet here, she might end up with an infection. I'm concerned. So I think it can go both ways, but they're just not used to, at least in our little subset of L&D, like voicing their concerns. They would just say, this is what we're doing.
Did you have simulations that went the opposite, to where the phissician could use the cuss and
No, I
part
didn't.
to the nurse?
No, but I didn't have any physicians there to do
Well,
it.
I mean,
I might have tried it.
I understand.
They weren't there.
No, I appreciate your project, and I think that it really goes, and it's very similar to my project. Like, one of the biggest key indicators was co-locating the physician
Yeah.
and nurse.
Yeah.
And it's that glass wall that really is a challenge there.
It
Because
is.
you even identified with, when you were like, oh God, I'd be upset, I'd cuss at you too if,
If they did
if
that.
you got
It was a lot. It was great learning. I mean, teamwork makes the dream work.
So I think that even that itself was
Yeah.
great learning, so thank you, Anna.
Yeah.
Thanks, Ed.
I'm just going to encourage you that accidental circumstance with your simulation and having role reversal, I think that's golden.
Yeah.
Because
It was great.
having nurses portray physicians and vice versa really gives insight
Yeah,
to
for
those
sure.
difference in their roles.
And I didn't see that coming, but it did.
All
Yeah.
right, we have one more presentation, so Dr. Coppola, you want to introduce your student, and do you have a jump drive?
Yes.
You can show right there. And you brought some guests, so let's see who's here.
You know,
Do you
Anna,
need some help?
that,
Do that little blue
what was
folder
like
on
the
the
Sunday that
bottom.
Judy invited us to go to,
Yeah.
like a couple months ago.
I remember. I couldn't call, but yeah.
Yeah, and so I participated in that.
Yeah.
And so what it was all the residents from the family medicine program at the VA
Okay.
came in and they learned how to communicate. Like, we had to practice SBAR. It was part of their residency program. Do you guys have a residency program?
We don't have residents. We just go.
Interesting.
Yeah.
Yeah. That was, it reminds me, like, that could be like a great, like,
They don't know.
All right,
Go ahead.
thank you. I'm Renee Cooper, welcome. And it's my delight to introduce Jackie Cooper, a nurse practitioner who came up with a quality improvement project that actually served, the timeline changed, which actually served her project well. I'll let her share about her setting and so forth for her quality improvement initiative with implementing a new tool for managing suicide prevention in the emergency department at a major metropolitan hospital. So welcome, Jackie.
Thanks. Well, again, my name is Jackie, and I'm a psych nurse practitioner. I'm also a postmaster's DNP student here. And the title of my project is Implementing Use of the Safety Tool for Managing Suicidal Patients in the Emergency Department. The setting for my project was the emergency department, also my workplace. Suicide, if you work in healthcare or if you don't, you probably have realized that it's an emerging problem. It continues to grow, which is especially sad because it's 100% preventable. As of 2017, no 2018 data available that I'm aware of. Suicide is the second leading cause of death for those between the ages of 15 to 29. And in the United States, it's the 10th leading cause of death overall. The suicidal patients often present to the emergency department, kind of like was alluded to in an earlier project. Community sites and outpatient settings are closing down, and people come to the emergency department to get care instead. So the problem statement, kind of the motivation for this project, is that the psychiatric clinicians working in this particular emergency department are not using an evidence-based or specific tool to assess and manage suicidal patients in the emergency department. And obviously, some problems associated with that are that how do we know that the assessment is even happening? And if it is happening, is it being documented? Is it documented in the same place in the patient's charts? How is it being documented? What is being documented? And if we're not using an evidence-based tool, how is that impacting the clinician's confidence and the quality of patient care? So then the literature review, one of the, big findings is that we do need to identify those at risk. We do need to assess for suicide. People who are committing suicide had interaction with the healthcare system within a year of their death, and this is an opportunity for an intervention. This is an opportunity to make a change and a positive impact. So assessing for suicide is also a Joint Commission National Patient Safety Goal, as current as 2019, but I think dating back as far as even 2009. So this has been a really big point of emphasis for a really long time, and the fact that it's still a patient safety goal really points to the fact that it's not getting better. Literature also says that it's not enough just to screen for suicide. You can't just ask someone if they're suicidal or if they have a plan for suicide, but it needs to be more of a comprehensive process. When you're just screening for suicide, you're getting a lot of false positives. Screening for suicide kind of shows you who is not probably going to act on suicide, but doesn't really point to those who are at highest risk. It also doesn't give you a framework for the next step. So once you assess somebody for suicide and they say, yes, I'm feeling suicidal, then what do you do? What kind of interventions do you do? Do they need to be in the hospital? Can they be discharged? And this really points to a gap in suicide assessment and management of suicide. Literature says that clinicians over-rely on self-reported suicidal ideation. So again, just because somebody says that they're suicidal doesn't mean that they're necessarily at risk for acting on that. It's not a reliable risk factor for suicide. And suicide assessment is only one aspect of a complete risk formulation. It also needs to account for protective factors and other things that we'll talk a little bit more about next. Literature says that a risk assessment should be dynamic. It shouldn't just be that assessment, but it should also account for protective factors, modifying factors, and risk factors. You should also be able to obtain collateral from outside sources. For example, the patient may be unconscious, they might be uncooperative, they might be unreliable. And so a process for assessing suicide that allows you to talk with family members or other healthcare providers is ideal. A suicide assessment should also be able to be adjusted based on the particular patient, and no two people are alike, and so no one screening tool is going to be able to appreciate all of those differences from person to person. It should be a collaborative effort, mentioned on the last page about being able to get collaborative information from family members, healthcare providers, guardians, other sources. But collaborative meaning but between the patient and the provider, being able to develop a therapeutic alliance between patient and provider is a protective factor in itself. You're making a human connection, and it also improves the patient experience. It also improves the quality and reliability of the information received. If the patient feels like they can trust the provider, they may be more forthcoming with information, and the quality of the information received is likely better. So not only did we look at, why is assessing for suicide important, but also the clinician and the provider's experience, their perspective was looked at a little bit. Clinicians don't always feel confident to assess for suicide. Sometimes feeling like if I ask questions about suicide, I might make somebody feel suicidal. And a lot of clinicians, whether they're psychiatric or otherwise, just feel undertrained and underprepared in their ability to assess for suicide. On the same other side of the same coin is that while they feel undertrained, they value that training, that people want to help and people want to be able to intervene, but maybe again don't feel prepared and don't feel confident in their ability to do so. 80% of sentinel events were related to inadequate or incomplete suicide assessment. And sadly, the literature shows that when providers don't feel confident in their ability to assess for suicide, they just don't do it. And this is obviously a huge miss. So the aim of this project was to provide optimal care to suicidal patients by ensuring that all are assessed and treated according to best practices, the use of the safety tool in this case. The safety tool allows for more specialized treatment interventions on a case-to-case or patient-by-patient basis, would improve care by improving clinician documentation, and also to improve the clinician's confidence in their ability to treat this challenging population. The method designed for this study was a one-group pre- and post-test. There were 6 psychiatric clinicians in the emergency department that participated in the study, 4 nurse practitioners and 2 physicians. They each received or participated in a learning session where they were introduced to the tool and kind of the intervention overall. They did a pre-test, 8-question, 5-point scale, and then some additional qualitative questions. They did the pre-test before the intervention and a post-test after the intervention. I spoke a little bit to the setting, but it was the emergency department in a large urban hospital. It's a pretty large emergency department. I can't speak to how many beds exactly, but within the emergency department, there's a 7-bed mental health suite just for the mental health patients. It's staffed by an ED nurse, a psychiatric provider, and assessment and referral clinicians. I mentioned the participants. There were 2 psychiatrists and 4 nurse practitioners. Again, the intervention was the safety tool. Safety stands for suicide assessment and 5-step evaluation and triage. The 5 steps are to identify risk factors. Is the patient intoxicated? They're at higher risk for suicide. Do they have suicidal ideation with a plan? They're at higher risk for suicide. Do they have prior attempts? All of those things. Also to identify protective factors. They may have a really supportive family who's here in the hospital with them. They may be part of an intensive outpatient program. Those things are protective factors. And then to actually conduct the suicide inquiry, and that's the actual suicide assessment. Are you feeling suicidal? Do you have a plan? Do you have intent to act on it? And then based on those 3 previous factors to determine an overall risk level. So after you've looked at the risk factors and the protective factors and done the suicide inquiry, is this person at high risk? Is this person at low risk? Or maybe a more moderate risk? And then to document that. The safety tool was developed by SAMHSA and the Suicide Prevention Resource Center. And it's also been endorsed in a couple of different research studies because it adheres to the Joint Commission's National Patient Safety Goals, which I mentioned earlier. And it also holds up to medical legal scrutiny, which maybe sometimes we don't like to talk about, but it's kind of a real thing. It holds up to some of that better than other tools because it is a comprehensive and collaborative tool. And some studies also recommended it because it's comprehensive but also efficient. Here's a pocket guide of the safety tool that clinicians can carry around with them if they're going to use it. Kind of just outlines the 5 steps and talks about some of the sources behind it. In terms of measures, one of the process measures I mentioned before was orienting the clinicians to the tool. There was the learning session that took place prior to the project where the providers were given a case study where they kind of went through how they might care for that patient according to the safety tool. And there was also a smart phrase embedded in EPIC, which was the electronic health record at the hospital, that made the documentation part of the safety tool really simple. They could just type in the smart phrase and it would prompt them to identify their overall risk level, the protective factors, and the risk factors. Outcome measures, the goal was to have a 50% increase in the patients that were assessed for suicide. So this was measured by gathering data 4 weeks prior to the intervention and during the 4-week intervention period and comparing how many patients were assessed for suicide beforehand and how many were assessed for suicide during the intervention period. just go back to that. A percentage was selected rather than a number, not knowing how many patients, would be in that group beforehand. Another outcome measure being measuring clinician confidence and aiming for a 25% increase in clinician confidence in managing this patient population. This was measured in the pre-test and the post-test. Like I mentioned before, there was the Likert scale questions, but also more qualitative questions where demographic information was collected, also anticipated barriers, those kinds of things. So the results showed that the participants did use the safety tool. Rates of suicide assessment in the 4-week period prior to the intervention were 61.36, and after the intervention, or during the intervention period, were 85.14. Confidence also increased from 85.8 on the pretest to 94. I think I mentioned it on a future slide, but one of the kind of interesting things is that I don't know if only 61% of people were being assessed for suicide beforehand, because the documentation wasn't always in the same place. It was really hard to find in a chart review, and it may have been there, but I didn't have time to read 100 charts. And so that's really one of the benefits of the safety tool, is that you can find it easily in the patient documentation. I spoke a little bit about the demographics, but this was some of the information collected on the pretest. 2 psychiatrists, 4 NPs, a range of practice anywhere from 1 to 10 years in the field of psychiatry or mental health. And then the clinicians had anywhere from a few months to a few years working in the emergency department setting. Primarily, these are clinicians that work in other areas of the hospital, but might work in the emergency department on call over the weekend or when there's additional coverage needed in the emergency department. All of the participants had prior training on suicide assessment, and 4 had heard of the safety tool in particular. So these are the outcomes. This measures each of the 6 participants. The red bar indicates their confidence level on the pretest, and the gold bar indicating their confidence level on the post-test. So you can see that overall there was some improvement there. And this graph demonstrates changes in rates of suicide assessment before the intervention and then after the intervention. Some other findings, other than those initial results, is that the tool really does encourage engagement with patients by open-ended question and conversation. This was identified by the participants as one of the bonuses of the tool, that it can be uncomfortable to use at first, but really it's kind of highlighting work that's already being done, and it can be adapted to each clinician's preferences and styles in working with patients. It didn't do any extra work, which was one of the anticipated barriers by the participants beforehand, was feeling like using a new tool might make more work. But again, rather it was just kind of a new way of organizing things that were already being done. We know people were asking about suicide, but it was just doing it in a more organized, comprehensive manner. Before the DNP project was done, there was a visit from Joint Commission to the hospital, and on the inpatient mental health units, they identified needing more consistent and more organized documentation regarding suicide assessment. So it was kind of timely in that regard. In the post-test and post-interview, all 6 of the participants indicated that they planned on continuing using that SMART phrase in the electronic health record. And I think 4 out of 6 indicated that they would continue using the safety tool as a whole. Also, at the same time that I was implementing my project, another part of the emergency department, the triage nurses were starting to administer the Columbia scale for suicide, which is similar but different to the safety tool. And so this was kind of good and bad and confusing all at the same time. I'll mention, a little bit in the future, but that's not necessarily a bad thing. So discussion is that the findings from my project were really consistent with what literature says, that training can benefit clinicians, confidence in working with this population can improve, and that also suicide assessment is important, that we're assessing for suicide more consistently when we're using a tool, or at least documenting it more consistently. And also results from my study really highlighted the collaborative nature of the safety tool and the importance of that rather than a simple yes or no questionnaire about suicide risk. And for now, the generalizability of the project is limited given the limited setting that it was implemented in and the limited number of participants, but that's an area for future work and an opportunity to expand. Given that this emergency department was within a larger setting, the project may be expanded to other emergency department settings or other areas within the same hospital, like the inpatient hospitals. Finally, there was an interesting study in the literature review regarding clinician confidence that said you may have a little bit of an improvement initially, but that over time, confidence really improves, and they attributed this to something called sleeper training, that maybe like you think you know a little bit more than you actually know up front, and that results may improve even further over time if people continue to use the tool. I mentioned earlier how the Columbia scale was being used or kind of implemented at the same time that the safety tool was being used by the mental health clinicians, and that in some ways these can be used as complementary tools. Maybe the Columbia scale that the triage nurse is administering can somehow auto-populate into the safety assessment that the psychiatric clinician is doing later on in the patient's stay. Acknowledgements, thanks to my project advisor and my site partner, and my references. Any questions?
Question. So your safety tool, was it like a paper tool that the clinician used, or was it integrated into your EHR?
The only step that was integrated into the EHR was the documentation part, where it documented the overall risk level, which was a part of the tool, documented protective and risk factors, which was a part of the tool, but the whole tool or that little pocket card that was showed, that wasn't in the electronic record, just a 3-line thing basically saying the risk level, protective and risk factors. Those parts were in.
Got it. And is that in like a note template then? Like a...
Yes. So within Epic, I guess it was referred to like a dot phrase. If you typed in .suicide, it was going to prompt the author to write in those 3 things.
Got it. Did you ever get the sense if it was something that was more integrated in the EHR, if it would be something that was more complied to with utilization?
Yeah, I think so. And I mean, working in psychiatry and working in the emergency department or on the inpatient units, we want to do a good job documenting. Yeah. This is kind of really a high stakes environment. And so I think, yes, I think the easier it is to use that, people want to and would encourage compliance.
Got it. Thank you.
I missed a little bit of the beginning of your presentation, so I'm not sure if you talked about it already. How did you get buy-in from the 6 people who participated?
Well, I work with them, and we're kind of close, I guess. I picked those 6 participants because I knew I was going to have a 4-week intervention period, and those were the 6 people that were going to be working during that 4-week period on call or so on.
So Jackie, if you want to talk about a couple of aspects in planning your project, you're waiting for the prompt in EHR so you have the best results because you knew the N number might be limited, but it was a good number for the number of clinicians that you were working with to shift practice behavior.
Yeah, there was a delay, I guess, kind of in the project because I felt like having that smart phrase or that information documented in the available to document in the EHR would really kind of improve the results. And so, but that was dependent on somebody else actually creating the smart phrase. And so that took a while, and I was afraid would reduce the amount of time I actually had to do the implementation, but it seemed to work out just fine.
Did you get any negative feedback in utilization of the tool? Like some providers felt like it didn't adequately cover what they were concerned about, or was it useful?
Not really. Mostly, is it applicable to every person who's here for suicidal ideation or suicide attempt? And I think maybe that's why all of the participants didn't necessarily plan on using it in the future with every patient, just as appropriate. Thanks.
Thank you. Concludes our presentations. Thank you, everybody. Well, not for you guys. You have to present some more in a little bit. Thank you.
So excited. Nice job.
Yeah, nice job.
Can I ask you a question about the page? Obviously, you got it afterwards.
Yes.
But even if you did, having the
Right.
because other teams